this was a video that was properly scripted, but it's not, so it could all go horribly wrong. It's not intended to be perfect. We're looking specifically at the communication aspects of what we're doing, which is a resuscitation. I would like one more helper, if possible. Could I borrow a resident from somewhere? You won't get... Thank you very much. Fantastic. Okay. So the scenario is this. A 50-year-old man has been brought into the emergency department in PEA arrest. History is that from the EMS, they've had diarrhea and vomiting for 3 days, had minimal oral intake, no past medical history is available because there's a maid and that's all, she doesn't know anything. And on arrival, CPR is ongoing. So, Ayman, can you come and do chest compression? Sif, can you take over the airway and manage the airway? Resident, I'll use you as a standby if you don't mind, and if you can do circulation and give drugs and put fluids in, and I'll try and keep the time as we're going on. Okay, so Ayman, can you do a bit faster? That's not really fast enough, and can you do more effective chest compressions than that? How is the airway? Can you manage the airway? Could you listen to the chest? And I'd like you to just sort of do all the things that you would normally do in a resuscitation. So you're managing the airway completely. You're doing chest compressions. So you've got a cannula. It's a small cannula in there. Can we get another bigger cannula? Oh, we've got another bigger one there. We need to give some fluids. They've given 200 mils of fluid so far. That's really not enough. So what we're doing at the moment is doing CPR effectively in cycles of 2 minutes, and every 2 minutes we're going to reassess the rhythm. We actually haven't assessed the rhythm while we've arrived, so can we just stop briefly? Okay, and we're looking at the monitor. It looks like PEA. Is there a pulse? There is no pulse. Thank you very much. Carry on chest compressions. I'm sorry, we haven't got a Lucas, so you're going to have to keep doing it. Okay, so that's 2 minutes from now. All right. We don't know when the last adrenaline was given by the ambulance, so we'll give one next cycle. So if you can get adrenaline ready, could you take some bloods for venous blood gas and other things? But as soon as you get a venous blood gas, if you can bring it back to me. Okay. And team, we need to look for reversible causes to try to find why this patient has gone in PA arrest.
I'm feeling tired now.
Right, can you take over, resident, if you don't mind? It seems likely that hypovolemia is the major cause, but listening to the chest, was there any, there's good air entry, no sign of a pneumothorax, retention pneumothorax? Right, okay. So we're going to, the history doesn't really fit with hypothermia, but we could measure the temperature. Hypovolemia, hypoxia, well, we're trying to manage the hypoxia. Have you got oxygen going in that?
Yes.
Yeah, can you make sure that there's oxygen going in, that we're not hypoxic? And as soon as you get the blood gas back, can you tell me the results? I suppose at some stage we should think of things like thromboembolic. Again, the history doesn't really fit with that, and a tamponade. Ayman, can you try and get hold of an ultrasound machine and then get it ready so that in between when we stop chest compressions, you can have a quick look to see whether there's a tamponade, maybe there's a very dilated RV. Okay? Right, it's 2 minutes. Can we stop? Can we do a chest pulse check? And no pulse. Thank you. And on the monitor it looks at PAA. Carry on, please. Right, can we give adrenaline, please? Okay. Thank you very much. Okay, any other thoughts, team? What we need to... How much fluid have we had so far?
2 liters.
Really? I think we've probably only managed the first litre. So if that one's in, can we give another one, please? Because I suspect we've... Okay. And I tell you, can we get a pressure bag to put that in rapidly?
Sure.
Okay.
Ultrasound is ready.
Fine. So next time we stop, could you actually get the probe ready? If you may have to come around the other side, get the probe ready so that because it's quite difficult to find. But see if you can sort of get roughly in the right position so that we can see whether there's a tamponade, or see what you can find now where we're going. But we've still got another minute before our next 2-minute stop is. Okay? Still happy with the breathing?
Yes.
It's going in easily enough, so there's no sign. All right, how's that blood gas going?
Still waiting the result.
Still waiting the result. Okay, thank you very much. Any other thoughts, team, as to what we need? Sorry?
RBS check we have?
Sorry?
Do you have RBS check?
RBS, you mean?
Blood sugar.
Blood sugar.
Yeah. We'll get that from the blood gas, won't we? If you can do that. All right. Okay. Start getting your probe ready, Ayman. We're going to stop in a minute and have another pulse check. Okay. Okay, it's now 2 minutes again. Stop. Do a ultrasound and a chest and a PA. We've still got PA on the monitor. Is there any tamponade there at all? Any no pulse?
No pulse.
Okay. Any answers yet, Ayman?
No, I don't see.
Right. Your 10 seconds is up. You're going to have to try again next time.
Okay.
All right. Carry on. All right. I'm going to stop the scenario there. All right. Okay. Because this could go on for a long time. Thank you very much, team. Now, we didn't script that at all. I had some idea in my mind. I gave him a few instructions. That was a sort of team scenario. We're specifically talking about communication in teams. There were some good things there, and there's things that really need to be improved. So again, we want your feedback. What were the things that you thought were good, and what were the things that you thought needed to be improved? We need the man with the micro. Oh, you're going to go first. He got there first.
So in team communication, the team leader was doing very good. He was he assigned the role and he was getting feedback regularly. But the team members, some of the team members were not following the closed loop communication. They were not closing the loop, and then some members were not very loud and clear. Even the leader was having difficulty in understanding them, so you have to be loud and clear.
Okay, that's a good start. Don't take it all, but that's a few importance. First of all, that the team leader was giving instructions and was giving clear instructions. I hope so, but they might not have been. Secondly, the team were very much being a passive team rather than an active team. All right? They were just looking, waiting for instructions. There are roughly two kinds of complex teams. There's vertical teams and horizontal teams. A vertical team is where you have somebody who leads and everybody waits to be told what to do, and when they're told what to do, they do it. A horizontal team is where everybody knows what to do and does it, whether they're told to do it or not, and the team works that way. And there has actually been evidence in resuscitation, specifically in trauma, where people actually published a paper on this and showed that a horizontal team is much more effective, that you achieve things much more quickly in horizontal teams. So you want a team where people actually aren't just waiting to be told things, but do things. Now, in fact, the team was doing it, but they were still just looking and waiting and not saying very much. As you said, they're very quiet. You also mentioned closed loop communication, all right? So this is where an instruction is given, and then somebody, so for example, can you give some adrenaline next time? And they reply back, yes, I'm going to give some adrenaline next time. If you don't hear that back, you don't actually know whether it's going to happen or whether it has happened. All right? So in this example, a good thing would to say, I want you to give adrenaline next time. And then they say, yes, I will give it. And then when the next cycle comes along, they say, I have given the adrenaline. And I say, thank you very much, you've given the adrenaline. So if you don't have that closed loop, you don't actually always know whether something has happened. Okay, any other points that people wanted to make? Sorry, there's a microphone coming.
The team leader just keep the team all the time, what he's doing,
regarded
Yes.
what he's thinking about the patients.
Yeah.
And he asked them if they have any opinion about what should be given. Just all the time keep them awake about the patients.
Okay.
What's going on?
Yeah, so there's two important points. One is the team leader communicating what the plan is so that there is an opportunity for the team to say, actually, I think we need to do something else, but also the team know what we're aiming for. And this is particularly important when we're coming to the end of the resuscitation and we're thinking we're not achieving anything. So we know that we're going to stop in 1 or 2 or 3 cycles if nothing has changed. All right? And the second point was giving the team an opportunity, actively saying, what do you guys think? Give me some help. This is difficult. Please don't leave me on my own. All right? So there's 2 important points there. Yeah, another one.
Communication to start before the patient arrives. Before the patient.
Sorry, what about it?
Communication to start the queue before the patient arrives or the patient is.
Yes, we didn't really go into much detail about that. It certainly would have been helpful if there are scenarios where you often do get information before the patient's arrived, and you can organize the team effectively so that people have clear instructions. Sometimes you get no warning, and you actually do that preparation as the EMS is handing over. So in this situation, I could have said, if EMS had just turned up in chest pain, I could have said, Ayman, you take over chest compressions, you do it tele to stop, Sif, you take over airway, and then get the handover or the endorsement from EMS. But there is no stop in resuscitation meanwhile. Any other important points you can think of? I can think of 1 or 2 more. You're very good, isn't he? Yes, I was deliberately doing a mixture. I was deliberately sort of trying to use some names, but I deliberately sort of didn't talk to the resident's name. I could have said, and what's your name, if I didn't know his name. But it's a good practice to specifically talk to specific people by name. Because if you just say, give the adrenaline, nobody knows if it applies to them. So nobody does it. Whereas if you say, Hamza, give the adrenaline, there's no doubt who I'm expecting to do it. So that's a really good important thing. It's helpful to know people's names and give instructions to a specific person so there's no doubt who has to do it. Any others? Sorry, microphone, because I can't hear you as well. It's coming behind you, Rez.
And the point still was clear and short, and the clear progress as well, and clear delegation to do the orders of the system from the start.
Yeah. Okay, I think that's about all I wanted to bring out of that. Thank you very much indeed, and thank you to the team.